Okay, so we are going to address this topic, management of thyroid cancer in children, which is not easy. So first of all, we need to define which is the age of the children. So this is obvious, but there are some controversies in the literature. For example, most of the authors say that children are those who are under 18, but many of the papers include patients with 20 years old of age. So we have to think about that, or you have to this in presence. Nevertheless, the thyroid cancer in childhood is about 1.8% of all thyroid malignancies, at least in the US. This is the data that I found. The incidence appears to be increasing, as Camilo told us yesterday. And there is an interesting difference between adolescents and children under 10 years. And the incidence in these adolescents is tenfold greater than in young children. So that's important to take into account. And also the female-male preponderance in these adolescents is 5-1, but this preponderance is not true in young children. So there are some differences also within the ages. The major risk for developing papillary thyroid carcinoma is radiation exposure, as some of you can understand very well. And in general, children, but especially those under 5 years old, are the most sensitive for radiation exposure. But nevertheless, the behavior, the clinical behavior of these patients is not different between radiation-induced papillary thyroid carcinoma or sporadic. The World Health Organization classified histologically the tumors in children, the thyroid differentiated thyroid tumors in children, in a similar way than in adults. So papillary accounts 90% of the differentiated thyroid cancer, and follicular are real and common. This is something we have to take into account. And other histologies are very rare. Papillary thyroid carcinoma are in general multifocal and bilateral. Regional neck lymph nodes metastasis appears in the vast majority of the children, and lung metastasis occur in up to 25% of cases, and this concurs with the lymph nodes. So people with lymph, or children with lymph nodes, has a higher probability to have or to present at the beginning with lung metastasis. And in the other way, the follicular thyroid cancer is typically unifocal, and hematogenous metastasis to lungs and blood can be appear, of course. The lymph node metastases are really uncommon, and this follicular thyroid cancer in the classification include other histologies like Hardle cell, clear cell, insular, poorly differentiated carcinoma. So in the previous slide, I've shown you some differences from the adults, and I summarize all of these in 3 points, 3 important points to take into account when comparing with adults. First of all, that thyroid nodules are really uncommon in children, but when present, the probability of malignancy is much more higher than in adults. The other is that papillary thyroid carcinoma are more likely, I have mentioned before, to have regional lymph node involvement, extrathyroidal thyroidal extension, and pulmonary metastases. The, however, despite this extensive disease, at clinical presentation, children are much less likely to die from this disease. That's very important because it looks like very aggressive, but the possibility of die is lower. It's 2% or less as a cause of specific mortality. And this is an important point. Pulmonary metastases in 30 to 45% are stable disease following the radioiodine therapy. And this is associated with a more favorable progression-free survival in children compared to adults with the same disease, which is also very important in order to stop the treatment in some patients and wait and see, which is sometimes a good option. And clinical response could be possible once we have stopped the therapy with radioiodine. Well, at the beginning, I told you that adolescents has a higher proportion of thyroid cancer than children under 10. So that's why some authors try to differentiate different behaviors depending on the age. In general, younger patient, as I told you, has extratheroidal extension, regional node involvement, distant metastasis, but what about under or above 10 years? Well, finally, in the literature, there is a not clear high risk of more extensive disease or higher rates of recurrence in this population. And they say that the treatment approaches, the genetic susceptibility, and radiation exposure could be also be more important than the age. So, but the authors say that maybe prepuberal or puberal, postpuberal could be helpful to understand different development of disease and behavior of the cancer. Well, once we have diagnosis, then a thyroid cancer in our children, what is the recommended surgical approach for the patient? So this is the recommendation of the IAEA Task Force on Pediatric Thyroid Cancer that has been published this year. I recommend you all to have a look. They say that total thyroidectomy is okay for the majority of the children, and they have some doubts about the therapeutic central neck dissection. They recommend in all children that has a gross extratheroidal invasion, which is difficult to see before the thyroidectomy. But anyway, always then local regional, of course, this is obvious, metastases on preoperative staging are present. If not, they say that you can consider selectively. The British guidelines, they say, they have no doubts about that. All children should go to total thyroidectomy plus central compartment lymph node dissection. So this is a nice recommendation due to the aggressive at the beginning. So as in other topics, I want to show you a case we treated almost 10 years ago. It was, she was a 3-year-old girl with non-familiar history of thyroid cancer nor radiation exposure. There are lymph nodes at the beginning, cervical lymph nodes. The ultrasonography showed global increase in thyroid size with multiple diffuse echoic formations, hypoechoic nodule of 2 centimeters, and multiple cervical nodes bigger than 2 centimeters. The cytology was positive for papillary carcinoma, but the thyroidal profile was normal, under normal limits, and there are no findings at the X-ray, hematological profile, liver and renal function, all were normal in this patient. So finally, the patient was treated with a total thyroidectomy plus bilateral in this case because it was present in the both sides, cervical lymphadenectomy. And the histopathology says that it's a papillary thyroid carcinoma of 1.4 centimeters with extrathyroidal extension, extensive vascular invasion, and lymph node metastasis. So was classified as a T3, N1B, and MX. So the next question in this patient is, should we treat with radioiodine? So let's see what the literature says about this topic. In general, the goals for the treatment using radioiodine are similar than in adults. So they are based in 3 states: eliminate residual thyroid tissue, decrease the risk of recurrence, and improve survival. So as in the surgery option, the recommendation is total thyroidectomy. So the question now should be, should we go to universal administration of radioiodine or selective? There are some pros and cons about this topic. So in favor of universal administration of radioiodine is that you have to think that these children, probably they have a long life ahead. So we have to take into account that the retention of normal thyroid remnant may decrease the sensitivity for detecting metastasis or recurrent disease by serum thyroglobulin or the diagnostic whole body scan with 131 iodine. So, but against, there are some comments. For example, no short, long, and long-term toxicities. To remember that there is a long life ahead for these people. The lack data of showing conclusive benefit for routine administration of radioiodine, the possible increase of in the risk of secondary malignancy, they are children, and there are some studies showing that thyroglobulin can become undetectable in patients with post-total thyroidectomy despite not having received the radioiodine. So the British Thyroid Association said, or has no doubt, they recommend the administration of radioiodine for all children, particularly those under 10 years. The ATA, the American Association, said again, or insist in classifying patients as a low risk, intermediate risk, and high risk. But remember what I mentioned at the beginning. One children with cervical lymph nodes has 89%, almost 90% of possibilities of multifocal disease, 20% of pulmonary metastasis, 30% of persistent disease after, and 53% of recurrent disease. So this is important to notice. So they suggest this workflow. I would say to try to avoid in some people, in some children, the administration of radioiodine. The only possibility to avoid this treatment is to perform a diagnostic whole body scan at the beginning using 123 iodine and TSH stimulated thyroglobulin. When there is no or minimal thyroid bed uptake and the thyroglobulin is less than 2 stimulated, is the only way to avoid the treatment of radioiodine. The rest of possibilities are conclusive to administrate. So this is more or less complex or simple workflow, but it's important to know when we should avoid a treatment in children. So in the case I presented before, we went for the the administration of radioiodine. So the next question is how to prepare this patient for the treatment. Should we go for recombinant TSH or just thyroxine withdrawal? Well, thyroxine withdrawal in the majority of the children will achieve TSH levels very high, only with 2 weeks of withdrawal. So that's important to notice. So the T3 supplementation is absolutely not necessary. When recombinant TSH is a possibility, the authors said that the typical adult dose could be administered to children, and in general, that's what I realized, that this recombinant TSH might have a role in specific situation in children. Of course, a low iodine diet is recommended as in adults. So we went for thyroxine withdrawal, only 2 weeks. Look at the number of TSH was very, very, very high, only with 2 weeks, and there is no problem with the children in terms of behavior or quality of life. So now we have to decide how to administrate the radioiodine. There are many possibilities depending on the age of the patient and the amount of activity of radioiodine. Could be in inpatient, isolated, or outpatient too, or just in between. So you can stay for some hours in the room and then go back to home. This depends on the safety of family members as classmates, patient age, of course, ability to comprehend the task required, the amount of radiation retained by the patient, and the potential exposure time and distance between patients and others. Of course, it will be necessary adjunctive therapies like hydration, regular bowel evacuation. You have to take into account that children are more frequent the nausea and vomiting in these cases, so also the administration could be not exactly orally, but could you inject in some cases the iodine in terms, remember our patient has 3 years, so we didn't know really if this patient has any problem with the pill, and accelerating, of course, the clearance of radioiodine. So now we have to decide the doses. There are 2 possibilities, as you know very well, the empiric dosing and the whole body dosimetry. So the empiric dosing could be reduced by 2 possibilities. One is the body surface area, and the other one is the body weight alone. So there are some recommendations in the European Association of Nuclear Medicine guidelines about this, and here you can see different examples according to the age. The age is, well, the height and the weight is more or less known at these ages, so this is the reduction should be done with the empirical dose. And we can leave this whole body dosimetry in cases with diffuse long uptake of significant distant metastasis with multiple radioiodine treatments, and when there is a limited bone marrow reserve due to previous treatments. So this is the case of our patient. This is the thyroglobulin, more than 8,000, with negative antibodies. We administrate an empiric dose using BSA of 100 millicuries for adults, so that means 39 millicuries. And this is the whole body scan performed after 4 days. Here you can see rest of thyroid and a diffuse uptake in the lungs consistent on lung metastasis. So what are the acute or long-term risks of radioiodine therapy in children? Well, are similar than in adults, but, and this was mentioned by Marcel Stockel yesterday, so we have only, I have only to say that, again, these are children, so long life ahead, so gonadal damage should be taken into account, especially in postpuberal testes. And, well, there is a possible increased risk of second malignancy, and in those patients, like I have presented to you, with pulmonary lung, diffuse pulmonary lung metastasis, the fibrosis could be a possibility. So we have a patient with a lung metastasis, diffuse, with a very high levels of thyroglobulin. How should children, or these children with pulmonary metastasis, be managed? Well, in general, these children with diffuse pulmonary metastasis are very good candidates for radioiodine. So after the activity of radioiodine, TSH suppressed level and imaging should be monitored for that. And if persistent disease or disease progression after 1 year, a further evaluation should be performed. So the next question is retreatment of radioiodine avid pulmonary metastasis in this patient. So when progression of disease and previous response is an option, when in some other cases should be individualized, the treatment based on the clinical course, the side effects, the risk tolerance, and the cumulative administrative radioiodine. And the guidelines and the literature insist, and this should be performed by experts or people who, with some experience with managing children with pulmonary metastasis. This is the clinical evolution of our patient. This is the first treatment with thyroid withdrawal. This is the thyroglobulin. But look at the second treatment. We increase according to a higher dose, and also the increase in height and weight of the patient. But there is an increase in the thyroglobulin. The whole body scan was similar. We administered another one, 72.5, with a mild decrease, but also there is a mild decrease in the next one. So we stop here and look at the thyroglobulin with suppression of TSH. Was 400, 400, 600, 500, and 507, the lowest after some years. So we stop here, and the last whole body scan was after the treatment was like this, very similar than in the beginning, without any exception of the remanent thyroid gland. So how to manage this? So retreatment of pulmonary metastasis with radioiodine is not recommended when children don't have uptake, of course, but also when it is not demonstrated a previous response of radioiodine. The pulmonary function should be considered, the test should be considered in these patients, and systemic treatment for advanced thyroid cancer in children remains unstudied, but should be performed is an option, should be performed in specialized centers. So you should consider to consultate with the expert, and clinical trials are in these cases preferred, and when unavailable, maybe kinase inhibitors may be considered. So in conclusion, and before just approaching the coffee, almost in time, I can say that ablation has been successful in the majority of pediatric patients after a single dose of radioiodine according to the reduction body surface or weight. 2 weeks of thyroxine withdrawal is very well tolerated in general for children, and we can use the recombinant TSH just when medical comorbidities appears in the patients. The fixed activities of radioiodine for treatment or locoregional distance metastasis should be downgrading and adjusting depending of the VCA or the weight of this patient, total body weight, and whenever possible, especially in those with with a lot of metastasis and no clear those who need more treatments, the whole body dosimetry should be performed when metastases are present. And this is two papers that I recommend to you to review if you have any patient with this age. Thank you.